Good afternoon, and thank you for joining me for another Leadership Rounds. I'm Dr. Rod Hochman, President and CEO of Providence and the Board Chair of the American Hospital Association. This past year has been like no other year, with the pandemic, as we all know, taking a toll on the country and our health systems. On the positive side, we've seen our hospitals and health systems, our staff, our caregivers step up and work tirelessly. They've served patients and communities with compassion and commitment. And personally, and for the AHA, we couldn't be any prouder of all of you in our hospitals, our nurses, our doctors, and all of our caregivers. But simultaneously, the pandemic has brought a lot of grief and suffering, particularly on the population. And as we're seeing the different variants that we're going through, it's shown a lot of weaknesses on our health system, right, that we've been able to see. And our supply chain, our staffing, and basically a public health infrastructure that in a lot of ways has almost been non-existent. Our guest today has been recently published his thoughts on the very topic of preparedness. How do we move forward, drawing on the lessons learned, putting new practices in place to ensure that the hospital field and our country are better equipped for the next public health emergency? We'll talk about how our field can learn from the pandemic, and also, what are we going to do next? I'm really pleased today to welcome Dr. Ken Davis, President and CEO of the Mount Sinai Health System in New York City. Mount Sinai is one of the nation's largest integrated health systems, which includes the Icahn School of Medicine, 8 hospitals, and over 300 ambulatory sites. As a neurobiologist, Dr. Davis has done pioneering research that has led to the FDA to approve 4 of the 5 drugs for the treatment of Alzheimer's disease. He has authored or co-authored more than 575 scientific articles and has been recognized as one of the most highly cited researchers in the field of brain diseases. Dr. Davis has been a leader in the move away from fee-for-service to population health and value-based healthcare, and really aiming at keeping people healthy and keeping them out of the hospital. And I know that perspective will guide some of the discussion to come around public health preparedness. Dr. Davis, welcome. Great to have you with us, and let's dive right in. Ken, you recently had an opinion piece published in which you talked about the preparedness for the next pandemic. It's sobering to think about this, and we're still emerging from COVID. We're really still all in the middle of it. But it's a reality that some of our communities are going to have to face. Could you share a little bit on the how and why our hospitals and health system must be preparing for the next public health threat? And the second part of this, what have you learned at Mount Sinai during this pandemic that will help you do things differently and practices that you'll adopt and carry forward?
So let's start at the beginning and give you some history of what it was like here. We've had 2 waves in New York. The first was the spring of 2020. And the worst day we had over 2,000 COVID patients, which was extraordinary. We had 88 people dying one day. We were overwhelmed. We had doubled up patients in ICUs. We had beds in the atrium of our hospitals. We had a big tent in Central Park where we were putting patients. That's just not where we want to be. What it speaks to is our lack of preparedness, thinking that the last time we had an epidemic like this was 1918, and it's going to happen every 100 years, and we really didn't have to worry about it. But we do have to worry about it. And what we've learned is, should this happen again, we don't want to put people in tents in Central Park, and we don't want to double up ICUs. And we don't want patients in our atrium, the entryway to our hospitals. We're going to have to build infrastructure so that we're prepared for a possible surge. So that's at least a start of what we have to be thinking about. But there are other lessons that we've learned. We're critical involved in responding to a pandemic like this is the ability to test and trace. You don't know what you have if you can't test it. And that meant very early on, we needed the capacity to sequence this virus. And after sequencing it, to develop antibody tests so that we would be able to identify when people had the virus. If we can't identify it and identify it quickly, we can't trace, we can't quarantine, we can't do all the things that are necessary to contain a virus, to contain the pandemic. So going forward, we really have to do a much better job of being prepared to do all that sequencing and diagnostic development so that we really can test and trace much quicker, quarantine much sooner, and control a pandemic. I hope that's an important lesson that we've learned from this. That means the supplies have to be available, the expertise has to be available, the capacity has to be available. We just need to be ready. Will it happen again? Is this going to take another 100 years before we have another pandemic like this? I rather doubt it. Let me give you my worst case scenario, which goes something like this. This virus we know mutates. And the more it's transmitted, the more likely it is to mutate. And it's transmitting like crazy in the rest of the world. My biggest fear is that we're going to get a variant that our vaccines currently don't respond to, that our vaccines are not effective against. And then we start over again. And until we control this around the rest of the world, that remains a real possibility, which emphasizes the importance of global responses to these pandemics, the necessity for the United States to be a leader and to be able to be out front in getting vaccines available, making diagnostic testing available, because if we don't, we're going to find out that when the rest of the world can't control it, it puts us at risk too for mutations and variants. So those are my initial thoughts.
You point out that we are ready for the next pandemic or natural disaster, or sadly, even a mass shooting or other tragedies. Any thoughts on how we can balance the need to be efficient, lowering costs, making sure that care is affordable, while still ensuring that resources are available for a high level of preparedness?
You've raised a very, very important question here that really makes us think about the economics of how we fund healthcare. And let me use Mount Sinai as an example of a not atypical healthcare system. Close to 65% of the patients we take care of across our 8 hospitals are paid for by either Medicaid or Medicare. Expenses in New York, a largely unionized environment, are very high. So in Medicaid, for Medicaid patients, we lose 35 cents in every Medicaid dollar. And in Medicare, we lose 15 cents in every dollar. That means that the margin that we have is all driven by commercial insurance, and it's extremely narrow across our healthcare system. That means we don't have the ability to put aside money to make the kind of investments that you'd like to see so that we could be adequately prepared going forward, because we have to take care of our day-to-day operations. So the government needs to step in here. When the government talks about being prepared and having a bill on infrastructure, there are lots of components that they're not considering around healthcare that they really have to address. The most obvious and simplest one gets back to my point about doubling up ICU beds, not having the capacity to expand, not having the capacity to surge. That requires an investment. And it's an investment in space that may largely go unused except in special circumstances. But it also means an investment in people. We have to have the staff ready and trained so that they can be deployed to the right places. We had to take people, nursing staff, physician staff, from places like rehab and psychiatry to treat patients with infectious disease. Now, they haven't done that, some of them, ever, let alone in the middle of a pandemic. Where will we find the time to take them out of service and train them up so that they feel confident and competent in doing that going forward? That all costs money. If we're going to run our hospital systems at a 0.5% margin for a lot of systems like the Mount Sinai system, we just have to realize that that preparedness is not going to be there. We really have to think through, how do we fund our healthcare system so that the margins aren't so narrow that we really can't surge up when we need to surge up. So I worry about the economics of healthcare. And that leads to a question that I know is on a lot of people's minds that I think we should talk about, and that's healthcare inequality. The pandemic brought to the forefront what those of us with the kinds of communities that we serve at Mount Sinai know, and that is that healthcare outcomes are not equivalent across all peoples. That in New York, Black and Hispanic people have poorer outcomes than a lot of our white patients. There is no greater socioeconomic disparity that exists almost in the country than exists across the two adjacent zip codes that Mount Sinai Hospital sits on. South of us is very affluent east side of Manhattan. North of us is East Harlem. And we need to treat patients in our hospital system the same, no matter where they come from. The same physicians, the same staff, the same infrastructure. We do that, but at a great cost. And if you repeatedly underfund Medicaid to the degree that we do, and then at the same time advocate for healthcare equality, you're not producing the kind of policy that is going to make it possible to truly have healthcare equality. If patients south of us are having to reimburse the hospital at 150 to 200% of Medicare, and people north of us we're losing 35 cents in every dollar, it becomes very difficult to provide the kind of care we want for everybody equally. Then when you add to that the sociodemographic factors that make it so hard for people who are in the zip codes north of us to have, it's all that more difficult. Whether it's food insecurity, whether it's inadequate housing, so many issues that make it hard for people to have the same healthcare outcomes. And we've got to address that as a country. We have to address those sociodemographic factors, which go beyond the walls of our hospitals. I can't do anything about food insecurity. I can't change filters on HVAC systems, air filters that haven't been changed in so long that patients with asthma and COPD are challenged every day they return to their homes if the NYCHA housing here isn't routinely changing filters. So I can go on and on with those factors, but we just can't turn our back to them and say, oh, this is horrible, and not do anything about it on a policy level and spend the money that's necessary so that the sociodemographic factors don't keep driving such poor outcomes.
You are exactly right. And that is where I was going to go with my next question. So thank you for that. I know that Mount Sinai, along with many health care systems, are doing a lot of work with population health and trying to address and close some of the gaps in care that we're seeing. And as a bit of a tangent or connection, we also saw the pandemic put a spotlight on the gaps and on the limited infrastructure for public health. If you might share your thoughts on what changes need to happen. We saw hospitals and health systems needing to step in and serve as the de facto public health system in some communities in both urban and rural settings. Some of these issues have been tied together. Any additional thoughts on this topic?
Let's take a step back because you raised the issue of population health. As long as we're in a fee-for-service system in healthcare, we as providers are incentivized to take care of the sick, and we have no value in keeping people well. When people become sick, we're able to generate margin. If people stay in their homes in a fee-for-service system and they're all healthy, our hospitals are empty, what are we going to do? How do you make that work? You make that work if you change your system to a system of value in which we have a population health model in which we are paid at the beginning of a year, for example, to take care of a large population of patients. And that amount of money we have is fixed no matter how much care we deliver in the hospital. So that means we're suddenly incentivized to keep people well. And when we have those kind of contracts with insurance companies, which we are increasingly trying to do, and when the government, through its intermediaries, facilitates value-based contracts, suddenly you begin to look at the resources that come, the dollars that come with those contracts, and say, you know what? We've got to be proactive about keeping people well in the community. So at Mount Sinai, for example, that means we will hire community workers, identify those patients who, by history, have been the greatest users of the healthcare system, and try to identify activities we can engage in that will diminish the likelihood that they'll need the hospital and keep them well in their homes. That's a whole different kind of healthcare system when you are proactively using case managers and local community workers to go out, knock on the door and say, did you take your medicines today? Let's make sure you did. Do you know when your next appointment is? Let's make sure you get there. Do we need to help you to get there? What do we have to do to look at that? Let me open your refrigerator and see what kind of foods you have. Oh, do you realize that with your type 2 diabetes, this isn't good food for you? Let's walk to the grocery store together and pick out the right foods. Or let me give you a list of things that I think you need to have. That's what we do when we move away from fee-for-service to value and risk. I think the sooner we do that, the better our healthcare outcomes are going to be, and the more we can deal with healthcare disparities.
That's great, and that's exactly where I think we need things to move. I'll end with one question, Ken. One thing that we've learned from COVID that we have to, that if you collaborate, you do better, you do well. We both are part of large integrated health systems. So I think a good question to close, how is scale or being a network system help you navigate this pandemic?
Scale is very important. Lots of levels. The first place, it provides efficiencies. At any single hospital, it might be inefficient to have all the people you need allocated to some particular areas. Obviously, by having a big system, we were able to consolidate ICUs, put better care in a few ICUs with many, many beds rather than many ICUs with little beds. It also allows you to have the people with the most expertise to be in the right places and to have them used most efficiently. Because if you're simply one hospital and your expert is only spending 20 or 30% of their time on the particular problem that you're confronted with, that means that 70% of the time that expertise isn't being used. But across, in our case, 8 hospitals and 300 ambulatory sites, we were able to be as efficient as we could be. We also can disseminate best practices. We'd be surprised at some of the places where great ideas show up and we suddenly generalize them across our whole system. That can come from almost any level of the organization, from a president to the lowest level staff people. Somebody has a great idea and we all copy it. And last of all, of course, clout with the size of our system makes it possible for us to buy supplies at a good price. So we're able to negotiate the kind of expense reductions that in a very small margin business makes our margins possible. So with scale and size, you get a lot of benefits.
Well, Ken, thanks so much for this thoughtful conversation. You and I could have gone on for another hour or so on this, and I always appreciate, the provocative nature of your thoughts. And as a fellow New Yorker, we're always out there kind of telling it like it is, and that's what you're doing. And as we're getting through these phases, I think we're going to need to talk more about how we exit, what we do, but more importantly, as you've emphasized with all of us, how do we prepare for the next round? And as you and I both know, this is not going to be the last time as we go forward. So again, thanks so much for being with us. We really appreciate it. And then I think to our audience, I hope you'll be back for our next leadership rounds. And as you can see from this conversation, we've got a lot of good topics, a lot to talk about. So thank you all for joining us today. And again, Ken, thanks for this great conversation.